let me start off. After the 3 talks this morning have just been spectacular, and there's actually going to be some fun touch points with each of them in this. But this talk really should have been called In Praise of Application. Okay, he did In Praise of Subjectivity, and sort of we're covering the spectrum of important things in statistics. I love methodology, I love theory, but what I'm going to talk about today is an application, something that I found unbelievably satisfying. That, full of the epiphany of discovery, everything else, and I kind of struggled. What should I talk about for this lecture, foundational? And it seemed to me that the real foundation of statistics is application. Because in an application, that's where the rubber meets the road. That's where you sort of take the methodology and take the theory and sort of revise your thoughts, because you're not just inventing problems. You have a discipline to try and get through that. And it's remarkable in this particular tale that I'm going to tell you how many different aspects came up and how interesting it was. I also want to dedicate this talk to 2 dearly departed friends, Larry Brown and Steve Feinberg. And I remember a few months ago talking with Larry, and I said, for this foundation lecture, I'm going to talk about my application. And he said, absolutely perfect. And what was so inspiring, Larry would often talk about applications with so much respect and awe that it was so important, because he was obviously a terrific theorist and whatnot. And Steve Feinberg, the same. Steve and I actually, Steve will sort of come up throughout a little bit this talk, and he was really valuable in sort of some of this research. So both of them, who absolutely could do any theory, could do any methods, but they also cherished application. So I want to emphasize that. Don't forget to breathe. I want to thank the scientific community so much for inviting me, and especially, given the lectures today, I'm very, very flattered and delighted to be here. Okay, so one of the big joys of an application is it's a group effort. We actually worked for about 2 years together. These are my co-authors on this project. This is at Wharton. Veronica, who's going to give the Bayari lecture, a powerhouse. It's going to be a detective story to figure out, what went wrong, or I want to show you where it is. And what turns out in this problem of public reporting is they want to report mortality rates of all different hospitals, 4,000 hospitals in the U.S. And there are some hospitals that have very low volume, okay? It's going to be heart attack patients, and maybe they only treat three patients a year. So you're going to have very small proportions kind of estimated from the data, maybe 1/3, 2/3, and so you have to borrow strength at all. Borrowing strength turns out to be really important in this. And what I want to really highlight, I'm going to start off with this. This is the sequence model that Judith spoke about. It's kind of the simplest model, Bayes 101, okay? And this is a setup that we all kind of think about theoretically when we introduce shrinkage estimation, and maybe theoretically, what do we think about, is shrinkage estimation safe or not? And so what we'll do is we'll say they're exchangeable and start off with this normal model. Here's the posterior mean. The empirical Bayes and fully Bayes would kind of do this too. You can sort of get to some heavy tails, but the behavior of this is going to be that this is going to shrink a whole lot towards the grand mean, right? When there's very small variance in a particular, very large variance. So as we know, if you observe data and some of the data has very large variance, it will get shrunk a lot by Bayes methods, but the variance is small, it won't kind of do the same. Now, theoretically, everybody thinks in this particular model, right, is, what should the tail behavior be like? So we'll get safety, maybe frequentists will think of when can you get a minimax estimate or whatever. But when it comes to an application, what's the first thing you should be thinking about? Is the exchangeability assumption really appropriate for this, okay? You have to have that these things all have the same mean and variance. And this is a fundamental oversight that's going on, as we're going to see. Notice I've put this in red because there'll be a red equation coming up. Another thing, and history is very important. This is sort of estimating hospital or comparing hospital mortality rates for various things. And this kind of study goes way back. When I was a graduate student, I remember hearing about the National Halothane Study. And so my teachers, they were involved with it, and it was turned out to be a big National Institute of Health study, as I'll show you in a second. But what this involved was 850,000 surgeries at 34 hospitals in a 3-year period. And it turns out, right, that 2% of people would die within 6 weeks of surgery. I haven't told you anything about the surgeries. I mean, are they serious? Are they not serious, et cetera? But the sick illnesses. But that ends up being a number 17,000. So notice, small percentage, you get a lot of deaths. So you want to pay attention to small percentages in this. What this was about was comparing different anesthetic agents. And halothane was a popular agent, and people were worried about some kind of liver trauma that was caused by them. And so now they had to take all of this data and now decide is what was in fact halothane problematic compared to the others. Not such an easy problem. In this, they reported, we'll think about indirectly standardization in a second, but the most important word here is standardized. If you're going to compare mortality rates of different things, you need to take into account patient sickness and whatever. You need to adjust for that so that you compare some sense what's the pure effect of halothane compared to the other things. They also found major differences between the hospitals even after standardization, which is kind of interesting and has some bearing for us, but that wasn't in the report. And just to show you, I'm being kind of sentimental here. I don't know if you can see, but this is the study that was here. And if you look, Fred Mosteller, PhD, right, was on the subject at Harvard. And guess who was just starting his PhD career? Steve Feinberg. Feinberg had gone to Harvard, and so he got kind of involved in this. And now if you look at the next page, boy, you see, here's Mosteller, here's Tukey, Yvonne Bishop, Feinberg in Holland, kind of the original Bible of discrete data analysis. Well, Steve got involved with Yvonne here with discrete data. All of this is contingency table analysis. So you see where this stuff, was sort of coming from. And then there's more very cool people on there, but let me not linger on it. Let me now get to the particular application. So this is what I was talking about when Jeff Silber saw this and sort of began to go crazy, but let me tell you what it is. There's a website called Hospital Compare. Yeah, you can go to it. And at website, their goal is to try and provide information about how well the hospitals in your area care for all their adult patients with a particular medical condition. I'm going to focus on AMI, okay, which is acute myocardial infarction, and that's a heart attack. You can see it there. But here, let's say I'm a user of the website, and maybe I'm sort of trying to understand mortality rates in the neighborhood, and I'll go to the hospital of the University of Pennsylvania, Thomas Jefferson, which is nearby. Here's a third hospital, Our Lady of Lourdes, and I look at the mortality rate at those hospitals. Well, they're estimated 16.6, 16.8, 14.3, but they have confidence intervals for them. But in any case, notice that they really look kind of similar, and perhaps there's no difference between these three. I'll call your attention, the volume of these is also a little different. Volume's going to play a role in what's going on. Well, this is the fact that drove Jeff crazy. Hospital Compare 2008, out of 4,310 hospitals, they said that 4,302 of them, right, were no different than the national rate. The national rate for heart attack is about 15%. Okay, and 0 hospitals were worse than the national rate. So, okay, now, right, so how did they reach this conclusion, right? Well, basically, as we'll see, the smaller the hospital volume, its mortality estimate is shrunk to the overall mean. Okay, so now alarms should begin to go off. Their justification is, well, look, for small volume hospitals, you have to rely on pooling the data. Now, I agree with you have to pool in some way, and so you have to borrow strength. But it's how you do it that turns out to be pretty important. What's a little scary about this, and why maybe this stuff is pretty important, is that hospital compare is now being emulated by all kinds of different centers. You see it in, when people are trying to now evaluate kidney transplant or organ transplant centers. Maybe one doesn't do it very much, and so if they're low volume, they can kind of get shrunk, and they'll be no worse than everybody else. Okay, there's all these sort of glamour contest rating systems that are going on. Okay, here's where Jeff went crazy. Hospital compares estimates contradict the conventional wisdom that mortality rates are higher at low-volume hospitals. Jeff said every doctor knows that, okay? If you have something serious, you want to go to some place where they have lots of practice. Practice makes perfect, okay? And we're actually seeing the kind of evolution of that in public health systems. But Jeff said it can't be that these low-volume places are safe, okay? Well, let's take a look and see. This is now the data that Hospital Compare starts with, okay? And this is what they end up reporting. This is raw data, okay? What this is this is now a hospital. Let's say the volume of this hospital, they treat 1 a year. Well, either the person dies or not. So their raw proportion is 0 or 1, et cetera, okay? So these are sort of just raw proportions. And you can kind of see that they trend down like that. This 15% is the overall patient mortality rate. And we just drew a smoothing spline here. This isn't Bayesian, but just so we can summarize what's going on, and you can see that there seems to be a clear downward trend. Anyway, at the end of the day, somehow, Hospital Compare ends up reporting these as the estimates. And look at these estimates, how shrunk they are for the small volume. And when I first looked at this, I said, oh yeah, well, it's probably just a normal model where it's shrunk. It's a little more complicated than that, and it took us some time to sort of figure out exactly how this is working. And there's really 2 steps that are going on here. Step number 1 is they're going to begin with the log linear random effects model that I'm going to show you, and you'll see the little red equation in there. Okay? And that's going to give you predictions. Now, those predictions are still going to be affected by patient mix, how sick the patients are that get to that hospital. So what you have to then do is apply some kind of standardization to adjust for patient case mix differences. And that's how you get from here to here, okay? And we'll sort of take it one step at a time, but it's kind of interesting now to learn this. And I find the idea of standardization quite fascinating, and I think there's just still, tons more important to be doing in there. Okay, so this is the data that we started off with. Medicare billing records, administrative data. This data wasn't collected to see how sick are people. Medicare is a system for free public health for elderly people, and so they just have they bill the doctors with this, and so now they have records of all the different characteristics of patients. Right, from July 2009 to 2011. There were 380,000 patients in 4,289 hospitals. Before we had about 950,000 in Halifax, so it's only about half of that. But the mortality rate is 15%, so a lot of deaths. A lot of deaths are happening. And by death, you mean death within 30 days of admission. Heart attack is a serious thing, an acute one. We had in our data 27 patient characteristics. These are sort of patient risk factors. You want to put them perhaps in a model. And we also had, we had several, but we're going to use 4 hospital characteristics. Well, we are in our models. The volume of the hospital, resident to bed ratio. That means, is it a teaching hospital? How many nurse to bed ratio? And this is a kind of a measure whether the hospital can really perform angioplasty or bypass or stent, kind of a technological measure. Anyhow, we did, with all of our data, we really did take 2 years, the first 2 years of data, and then we'll see we held it out. We did everything, and then at the end, and hooray, we actually got to compare things with the validation sample, okay, to sort of be honest in this. Okay. This is the Hospital Compare random effects model, okay? And we saw this, Alan actually was showing us random effects models. But this is just a straight logit model composed of logistic regression of a random effect for a hospital, and now this has the patient risk factors in there. Okay, so this is fixed effect. This is random effects. Okay, this is the probability that patient HJ, right, will die within 30 days. The alphas, remember the red equation? The alphas are modeled as simply random effects, normal with a mean mu and variance sigma squared. Okay, that's it. Okay, that's what's going on. And here the patient effects, the fixed effects, are just based on the patient characteristics. And this thing, they fit just using constrained maximum likelihood. It's sort of, Bayes with the flat prior. Okay. Let me just call your attention to just the naming system. This will come up later when in one aspect. Think of HJ as the name of a patient, and hospital is kind of their last name, and patient is their first name. Okay, so that's because we're going to be able to sort of send patients to different hospitals and stuff like that. Anyway, okay, here's what hospital compare is doing when you apply that particular model. You apply that model to the data, and remember what we saw before. It's not quite the same as this. This thing is really spread out, and you would certainly expect more variation, right, when the number of patients is small. But it's way spread out, and what happens is when you apply that model for the predictive estimates, they are shrunk quite a bit. The scale is actually lower. So things are shrunk down quite a bit. Each of these points is the mortality rate for a hospital, not patients. So we sum all the patients in the hospital to get the mortality rate there. This is the alphas. This is not quite their final report. It turns out it looks like the others, but what's happening here is, remember in our model, I've just shown you the predictions of this, and now I'm showing what the estimates of the hospital effects are, okay? And these things are getting shrunk like crazy. This is normality. This is what happens when you just apply a normal distribution to sort of shrink things, and you have a kind of exchangeable model over everything, okay? One thing just to call your attention to, because it's quite important that hospitals may have different case mixes. Some hospitals get sick patients, some don't. In fact, if I even call your attention to the green line here, it still isn't down to the red line. It isn't flat. It does look like the small hospitals still have a problem, but we don't know what that's from. Well, one thing we do know that it's not from is from the alphas. Because the alphas are so small here, it must be the case that the variation here is driven by patient case mix. So it's kind of interesting sort of separating the sources of variation here, and we can see what's due to the hospital and what's due to the patient, and it'll be a challenge to try and get rid of that patient case mix variation. Shouldn't hospital characteristics be in the model? Well, it'll seem like an easy question to you at first, right? The hospital effects have been modeled as just this normal random effects, completely random with the same mean and variance. Right. This is the assumption leading to the strong shrinkage of the alphas. Available hospital characteristics have been left out. What we're saying is that the hospital effect here is completely random. It doesn't depend on any characteristics of the hospital, that it has the same mean no matter what. Right? So the mean, we're saying as a kind of a prior, the mean of hospitals with lots of nurses will be the same as hospitals with very few or something, or volume even, okay? The plots I'm showing you are with respect to volume. Okay. Now, proponents of the hospital compare, and actually these are where discussions, I had a lot of discussions with Steve Feinberg about this, but he said that they would argue that including hospital characteristics in their model would be unfair to the hospitals. So we're thinking unfair to the hospitals, right? I mean, so I would then say, but look, isn't that unfair to people seeking accurate information, right? Yeah, and it's kind of obvious, whatever. But here's the thing, is that I think that hospital compare was initially devised as a method to kind of evaluate hospitals. And then somebody had the bright idea of publicizing this for mortality rates. So if it was just used to sort of assess hospitals, it might not be unreasonable, okay? But once you make it public, now you have to sort of give the most accurate information that you can. Let me give you an example. When you give students grades in your course, You grade them on their performance in your course. You don't look at how they did in other courses. You don't look at their education history or their socioeconomic status. Or you don't bring those things into play, even though they may give you better predictions. So in some sense, as a scoring device, I understand where they're coming from. But we sort of have an obligation, if we're going to make this public, to do it right. Okay. So first step number one for us, and there's going to be kind of a wow in this, where this is where, oh, we really have something here. But what we did is we decided we were going to elaborate their model. And remember the red thing? We go to a different red thing. And see what the difference is? These have little h's. Okay. So what we're going to do is we're going to make the mean and the variance a function of hospital characteristics. And so we're modeling now at the second level, not at the patient level, but at the hospital level, we're going to elaborate that hierarchical model. And I don't want to have lots of equations, but the first one is, we call it CC, because that's hospital compare. They just use the same mean for everything, a constant variance for everything. The second one is linear log volume. And so let me be, if I can just, and I can read it off to the other room if they can't see it, but just to show you, mu sub h, let's say, would be equal to gamma naught plus gamma 1 log vol. Okay. So can you see that over there? I'll do it here. Sorry. Mu sub h is equal to, so basically what we would do is now we're going to put a hierarchical, a hyperprior on these characteristics, okay, just to sort of build it up. So that's sort of the first step, and then we move to splines, because why should it be linear? And then we had and by the way, Veronica here sort of saved us. She went to this step with the spline and the log linear, and it was just magic. It had to be penalized spline, so it wasn't easy to sort of get to this, but we finally got it working. Here, I'm pointing to this. Sorry. Anyway, and then we added linear terms, and then here is we added actually an interaction, so which is kind of interesting. You might start thinking of the question, well, are young people much better off than as compared? I mean, is the boost from going to a small volume hospital even better for a young person? That kind of question. And it turns out that this helped us answer something like that. So as I said, CC is equivalent to hospital compare. This is very important in this. Each subsequent model here nests the previous one. And it's oftentimes makes sense to work with nested model, often when we're working our theory. But here, we just wanted to let the data speak. So what's great is you can see if you just apply this model, the data could say, hey, gamma naught is gamma 1 is 0. So don't even bother with this, okay? Well, you'll wait till you see how the data spoke, okay? So anyway, and et cetera, et cetera. Sorry, Tony. I loved your talk. But we did non-influential vague priors here. If the axe cuts the tree, then it's sharp enough. So we're just sort of using this to try and get stuff going. I do want to call some attention to this. When we first started this work, we were doing there's this wonderful Albert Chib probit model data augmentation that just was magic, whatever. But what about the logit? You didn't have that, so there was a sort of a T7 approximation, and you could do it, and it took forever, and what a drag. And all of a sudden, I heard a talk, Polson, Scott, and Windle, there's this polygamma augmentation that works for the logit, like a charm. It sped things up. We were off and running. I can't tell you just how much this saved us. Thank you, guys. Anyway. Oh, so here's the wow moment. Okay, this is hospital compares alphas. All of a sudden, you put this linear term in, look what happens. Okay, and this has now estimates of the gamma naught and the gamma 1. The gamma 1 is so many standard deviations or posterior standard deviations from 0. I mean, it's unbelievable. So to me, this is the data speaking, because the data could have chosen this. So you just do this. What I just said is we're emancipating the mean. We're letting it be free. I know, I get very emotional in this. But then here, this was the spline model, the linear one, okay? One thing that you should notice is we're seeing really, right, this is telling us right away, we don't know what the numbers are, but the mortality rates are clearly higher at the low volume hospitals just from this, okay? And then here's further adding more hospital characteristics and the interaction, and this is what the plots of the alphas look like, okay? I don't really have time to go, but it's interesting in the interaction why this all of a sudden gets thinner. And what's happening is we were modeling everything hierarchically at the second level, but it turns out when you do interaction, now you have patient-level data, and it has to move down. So the alphas don't completely capture this sort of hospital variation. Anyway, but that's just a graphic. Okay. Now, question. You know, to me, I think I'm convinced, but we should probably look at some careful model assessment. So, have predictions really improved? Okay. Well, and this was a good and important lesson for me. So I thought, well, you will do Bayes factors. It'll be terrific. And then I realized, or was advised, that don't use Bayes factors with vague priors. It's terribly unstable. The tails will just foul you up. So we couldn't do that. And what we realized, and this is now relates to Alan Gelfand in the Gelfand and Day, there were these wonderful papers in the 90s where he was saying predictive model selection, you should do it, you know, predictively, whatever, predictive Bayes factors. And I thought, oh yeah, that's pretty cool, but you know, what about regular Bayes factors? Well, regular Bayes factors don't work, so it's all you have here. So it's great. So what you do is you just sort of, kind of take the posterior from a vague prior on your first data, and then you use that as the prior on the rest of the data. So predictively, now we're doing this on the training sample. This is the training data, and this is the predictive Bayes factors. And just look at, I mean, these things, this is the log of the Bayes factor. They're really big, and they just get bigger and bigger and bigger. So that was very, very cool, okay? Just a philosophical point, I mean, all of a sudden I'm realizing with Bayes factors with vague priors, you can't use this. I mean, I thought, well, maybe instead of a vague prior, we'll use a more concentrated prior. But it would be crazy to use one prior for estimation and a different prior for testing. It just doesn't seem right. I don't care how much you want to get away from the paradigm. It's just not coherent. So in a way, you know, that's kind of a dilemma that we have to think of. If we're using vague priors for estimation, well, we're going to have to take a different route to Bayesian testing. Okay. Paul Rosenbaum is in this, and Paul Rosenbaum is quite interested in how well are these models really calibrated to what we're seeing, okay, and to what actually happens in the population. Because the predictive Bayes factors are gauging overall model fit. But the interesting question here is to see how well models are calibrated is let's try and look at how well they work on particular segments of patients. Okay? I mean, so this particular aspect of analysis turns out to also be quite illuminating. So what we thought is let's just see how well is it calibrated on low volume hospitals. Okay? Does it really compare to sort of what should be happening? So what we decided is we were going to compare model predictions to out-of-sample mortality rates on low-volume patients. And we kind of wanted to do it with high volume, but maybe the high-volume patients aren't as sick as the low-volume patients. So the way we get around that, right, is we did because we can't do an experiment, is we matched patients to the low-volume patients at the high-volume hospitals and then looked at what the mortality rates were. Okay, so I'm not going to go into this, but we did take a serious matching strategy where you can find distances between patients, and then, you know, so example, here's a low volume patient, and patient C would be matched with patient 4, something like that. In any case, this is a very telling chart. Let me just walk you through it, and let's just focus on the very first line, okay, because that's really what I found is fascinating. First of all, the observed mortality, now this is the out of sample. The observed mortality in the low volume hospitals is 28.3%. Very different than 15%. Okay? So all of a sudden, you sort of worry that the information that people are getting. Now, if you look at the mortality rate at the high volume hospitals, the top 20% high volume, that mortality rate is 12%. So that's better. But you could argue, well, how do we know that the patients just aren't really much healthier? Well, the match sample takes patients that were just as sick and looked at how they did at the high volume. And in fact, they do fare worse, but they don't fare that badly. So the rest of this is kind of hospital effects going on. Now, for our model, what we were interested to see is our model calibrated. Well, the CC model isn't. The CC model can't find this difference, but our model really can find that big difference. So here's a way, right? So we've used kind of, vague, non-informative priors, et cetera, but you can make sure if you're going to do these big Bayesian hierarchical models for prediction, you can make sure that it's calibrated sort of out of sample in terms of what you're doing. Okay, wonderful. Good. Now I'm going to tell you about standardization. Any questions? No, okay. And, thinking like a teacher. Indirect and indirect and direct standardization. So this is the problem. This is the problem of I've got my predictions, but I want to somehow remove from those predictions and now sort of get predictions that are adjusted for patient mix variation. Okay. So I want to sort of somehow standardize these things, right? We always think, right, subtract the mean, divide by the standardization. No, it's different here. I'm going to show you two approaches, indirect standardization and direct standardization. I'll argue that this is not the right thing to do, but it took a while to sort of figure this out. Both of these approaches make use of the fact that the mortality rate for patient, remember I said H is his last name or her last name and J is their first name? So this is a particular patient. And I can take any patient I want and get an estimate of what their mortality rate would be, right, at any hospital. So just in my mind. So here I'm finding what's the mortality rate for patient XJ at hospital H star, and I just sort of use my model to go backwards. So this is a counterfactual, okay? It's kind of cool. So you can start sending patients to other hospitals to see how well they would do. Now I think you're going to see the standardization idea. Here's what indirect standardization is. What they do is they take, this is now the predicted mortality rate, and they're going to compare it to the expected mortality rate. What does that mean? Well, they take all the patients who went to hospital H, and they send them to every hospital and look at the average mortality rate is. So this is how well all those patients who went to hospital H would have done overall, and you're looking at the ratio, the comparison, how much worse off they would be. And then they multiply that by the overall patient mortality rate, which is 15%. This kind of doesn't seem unreasonable. In fact, if you work in this stuff, you'll see that there's something called the standard mortality rate, which is kind of, this is a tradition. But if you think about it, this doesn't have any probabilistic justification. In fact, this number could be greater than 1, okay? So it's kind of crazy. It turns out it doesn't really eliminate the case mix variation. We see that. It's quite subtle, but you can kind of just think, well, look, but I'm sending the different patients around, and this hospital got stuck with, these sort of sicker patients. So maybe that's not right. And the thing that was very disturbing that we sort of realized at the very end is that this is systematically underestimating actual mortality rates. It's forcing the rates to be around 15%, and they shouldn't be. They're really much more dangerous, the smaller ones. Okay. This is just a picture of those, of if I apply these. This is taking the predictives, and this is what you would get. Taking the predictives, what you'd get. Okay, the predicted ones you get, and you can see there's still all of this patient mix variation going on here, okay, in terms of what's happening. Here's direct standardization. It's actually kind of an easy idea. What I'm going to do is I'm going to now send everybody to hospital H and look at the average performance. So the whole population goes to hospital 8, and what's their average mortality? The whole population goes to this one, whatever. And now it can't depend on case mix because everyone's got the same case mix, okay? So it works perfectly. It's easier to understand. It's interpretable. It's a linear scaling of the alphas, effectively, because you've removed the sort of the direct effect from your model. But now, those alphas had numbers like, -3 or something. But these are now really calibrated so they can be interpreted as actual mortality rates. It splendidly removes case mix variation. And here's the subtle point. It correctly calibrates to the actual mortality rates. So these are the calibrated mortality rates. These are the directly standardized mortality rates. And let me just call your attention to, there's a red line here and there's a blue line here. This is the average mortality. The red line is 15% average deaths, average mortality rate of the entire patient population. This blue one is averaged over hospitals, right? So every hospital counts one, every patient counts one here. For the red line, the small hospitals don't count very much, but for the blue line, because they have high mortality rates, that they, it brings the blue line up higher. So this is kind of the overall average over hospital that you're seeing, and it's much higher than the 15%. And if you look at where these numbers are going, this is our final model with all the interactions and everything. These numbers are getting up to 28%. So it's, it's just, remember I showed you 16%, whatever. The numbers are just wildly different, okay? And it's really kind of, it's a little bit frightening. Anyhow, okay. Now, uncertainty quantification, it's very cool. We're doing Bayesian, and so now we get this wonderful credible intervals as just a byproduct of doing it this way. Tony spoke about the uncertainty quantification seminars that are going. We saw uncertainty quantification in Judith's talk. It's a big thing now, and Bayesian credible intervals do it the right way. We may not know if they're exactly calibrated to the 95%, but they really give us a good sense of where it's large and where it's small. I think you get good relative comparisons. This is for the CC model. This is the intervals, the uncertainty intervals for 10 hospitals. This is the uncertainty intervals for 10 hospitals under the LC model. And for the SL model, these are the uncertainty intervals. Oh, and let me point out one little thing, because at first I was confused by this. So I looked at this and I said, let's just take the LC model. Everything is kind of shrunk here, so it looks like maybe there's not a lot of uncertainty. No. Each of these points is a posterior mean. So if I want to know the uncertainty about one of these points, it has its own posterior distribution. So there's 4,000 posterior distributions, and those are the 4,000 means. And what I'm showing you on this slide is just the uncertainty that goes along with each one. And by the way, I may not know if this is exactly 95%, but I can be pretty sure that there's a lot more uncertainty here than there is here. So relative comparisons using credible intervals, often in situations where maybe they're off, from frequentist calibrations, which I don't think is all that important, but here it's the relative thing that's really valuable. So we can sort of gauge and learn how to use these things. Okay. It turns out that the government's interested in classifying hospitals by their mortality rates, which are the good ones, which are the bad ones. If you did the CC model, okay, with our credible intervals, and we just see is it above 15% or below 15% completely, you'll see that hospital compare for all hospitals puts 30 or these are good. These are bad. High is bad. Low mortality is good. And it's kind of not really giving us much. It's really saying that among small hospitals there's no differences. And this is what it does with the high volume hospitals. But now if we go to our model, now all of a sudden there's a lot more worse hospitals, and they're mostly all the small ones. We can't promise you that a small volume hospital is as good low mortality, but what's really nice is now with our model, we actually can tell which of the high volume hospitals are the good ones. That's what you want to do. You want to make a sort of a fair assessment about what's going on. So we get that as well. Now, and this is my last technical slide, and then I'll just make some points. But in some ways, I think even though we were motivated by predicting and trying to get people honest information, and we'll think about that dilemma on the next slide for a second, but this was a byproduct that I realized, oh my gosh, this is really so important for proceeding with scientific investigations. Because what we now have is we now have directly standardized values for each hospital. This is like new data. It's clean data that can really tell us what the mortality rates are adjusted for the patient mix. So now we can, for example, look at plots of, let's look at the comparison between not having the technology and having the technology. And the mortality rates are much higher. So this now, as we sort of get further into investigations, will really help us. This is the nurse-to-bed ratio. There's a lot of work going on in the public sector about the value of nursing. You know, studies going on, and this shows quite clearly that having a higher nurse-to-bed ratio really, really improves outcomes. And there's debates about teaching hospitals. Are teaching hospitals, are you really better off going to them? Well, it sure looks like it's true to an extent, but you can begin to, you know, we just scratched the surface. There's many more things to do. Our model is we really want to just show that do this, don't do hospital compare, but there could be much, much more to do. So here we've seen that there's strong evidence that hospital characteristics and interaction should be included in the model. Okay, no doubt about it. Indirect standardization fails to eliminate the effect of case mix variation and underestimates the mortality rates. Okay, it kind of works for the CC model, but it doesn't work for those other models. Okay. This is the directly standardized should be the new gold standard for public reporting if you're going to do it, and for further analyses of what influences mortality. If we really want to understand this, we really need to do this kind of standardization so we can start thinking about these comparisons. And here's the dilemma, and this is one that, you know, really I went back and forth with Steve Feinberg about, and I think he's kind of right. We've spoken to Medicare about this. I gave a talk to the government people, and you know, the sort of younger people, whatever, or the people maybe not with full responsibility say, oh yeah, of course we have to do this, whatever. But the people who had to take action, they're sort of thinking, you know, should we really report this? Do you really want to report that the low-volume hospital? I mean, suppose you live in a rural area and the only hospitals you have are low-volume hospitals. You want to report that to people? I mean, this is information that maybe we can use to have a better public health system and stuff. But I wonder about the wisdom of sort of reporting these things. You know, there could be, for example, volume may not, at this point, volume may be a proxy for all kinds of other things that we haven't seen yet. We just have two coarse measurements. So sort of that goes on, and that's a question for you sort of to mull over. Thank you so much. I did.